Hello, everybody. Good morning, good afternoon, good night, depending where you are. And I'm delighted to welcome to this LTC COVID webinar. Today, it's going to be a bit different than the ones we've done before. We're actually going to have two presentations. So we're going to go a lot more in depth. And we're going to be discussing the role of ownership, the sector of ownership, so whether homes are in the private for-profit, non-profit or public sector in their response to COVID. And the webinar was in fact initiated by Florien Kruse, who's going to be chairing today. And this is going to be a collaboration to start with between Florien and Amy Xu. I'll just briefly introduce them and then I'll leave them to run the rest of the webinar. I'll come in at the end just to announce the next webinar. I'll just mention very briefly what it is and then I'll give a reminder at the end. That's okay, Florian. So the next webinar will be on unpaid care, will be on the 3rd of August. And we have some slots available if anybody has been doing any research that they'd like to share, or even if you have a short study or an initial study you'd like to advertise or to explain, we can have some small slots to introduce new studies. So that's for the 3rd of August. Today, we're going back to care homes and to the sector of ownership. I'm going to, first of all, introduce Florien Kruse. Florien, I'm not sure if I pronounce it right, I hope I do. Florien holds a Master of Public Policy from the Hertie School of Governance in Berlin. And she's currently a PhD candidate at again, I don't know if I pronounce this well, at Radboud University in Nijmegen in the Netherlands. Her PhD is actually very relevant. It's on the added value and ethical considerations of different business models in the healthcare system. And then our other speaker is Amy Xu, who's also been working on the LTC. In fact, Florian has also been working on the Dutch report for LTC COVID, and Amy Xu has been working on the Canadian report. Amy is an investigator at the Bruyère Research Institute in Ottawa, Canada, and she holds a University of Ottawa Brain and Mind Bruyère Research Institute chair in primary healthcare dementia research. Her research focuses on understanding the care needs of older adults across the continuum of long-term care, from home care to the end of life. So thank you very much for everyone for joining. Thank you very much to Florian and Amy. And Florian, you will let people know about the structure and how we run the webinar today. Thank you.
I want to welcome everyone. I'm very happy to see so many people are interested about this topic. So today we'll talk about the COVID-19 outbreak in the nursing home sector and how ownership matters. So I'm Florien, and I will be doing this project together with Amy, Marcelo, and Adelina. So a brief introduction. Adelina did already very well introduction of me. I've been working on ownership differences for 5 years now. I'm actually finishing up my thesis this month, and I've been working on how the for-profit sector or the private sector can contribute to a financially sustainable healthcare system. I've been working on the hospital sector. I started actually a European Foundation on this topic, and at the moment I have studied both the hospital sector as well as the nursing home sector. Recently we published a study about the for-profit nursing homes in the Netherlands, which I will briefly discuss later. So really the purpose of the seminars today is really to pitch the idea of this project, to provide a platform to exchange ideas on this topic, and to build a network of scholars interested and willing to collaborate. So it's maybe slightly different from other seminars we've done, because at the moment this project is still in its infancy and it's kind of new, and we want to kind of seek new ideas, thoughts, and collaborations. So the structure of the seminar is really that I will give a brief introduction, the theoretical mechanism, then Amy is sharing her preliminary findings from Canada, and then we want to make sure and reserve enough time, so I have prepared a certain interactive session where we can both share ideas and thoughts about this project and how to bring this forward. So at the moment we have seen few headlines coming up, and the nursing home sector has gained more interest over time While initially in the begin phases of COVID-19, the nursing home sector has been much more in the shadows, and at the moment it is catching much more interest from newspapers and journalists, but also how ownership matters has been catching interest lately and catching the headlines. But that sparks the question, why actually would ownership matter? Why is this important? Why is this such a long-standing debate, and especially also political debate? Maybe we should start first on what actually different ownership structures, what it actually means. So for-profit entities actually means that they are owned, the owners have the right to all profits. So every surplus that are made can be distributed to third parties, and they can enjoy the surpluses of that organization. While non-profit actually have a non-distribution constraint, which means they are prohibited to distribute any profits to third parties. And actually instead they are expected to serve their beneficiary stakeholders. You also have non-public entities. These are also non-profit entities, but these are legally part of the government and therefore under control of local or central governments. This looks very clear-cut. It is much more complex than that, of course. And I made, in my thesis, I made a spectrum of all the many shades of gray, in a way, of what can exist, and even that is a typology. But it can range from low commercialized, publicly owned, legally dependent entities to for-profit providers who are privately funded. So there's a big range to it. And even a colleague of mine and a friend of mine, Aline Bos, who just recently published her thesis, actually puts the private equity-owned providers in the highly commercialized end of this spectrum. And there's, of course, all kinds of other things that you can say about ownership types, in how far some people argue that non-profits are for-profit in disguise, or you have kind of how the external incentives make different ownership types converge towards each other. I'm going to skip this a bit, but it's good to keep in mind how much more complex the ownership types are. So this is a brief overview of what happens in different countries and how it very much differs between different healthcare systems, what the share of for-profit nursing homes are. And you can see, for instance, in UK, in England, you see a high share of for-profit providers, while for instance, in Norway or Denmark, it's much more leaning on the public services. And the Netherlands, for instance, has a fully private sector, but most of it are non-profit entities. As you can already see in the, as I say, last available year, or the amount of resources I used for this, it's very difficult to get actually good data on this. There's a lack of international data. There's no OECD, no Eurostat data. So I compiled different statistics together. And I know that the European Foundation actually asked different country correspondents to report the share of for-profit, non-profit, or public providers. So it's quite difficult to get a good grasp on how the different kind of ownership structures, what the market composition is in different countries. It's useful actually to understand to first kind of think about the theory, the general theory of ownership, to understand the response to COVID-19, how actually ownership might differ, might be an explanatory variable to how different nursing homes have responded to COVID-19. The first of all is actually efficiency. What kind of characterizes or symbolizes for-profit entities is that they have shareholders. And those shareholders, the theory is they want to maximize their profits. And therefore, they want the for-profit entity to maximize cost efficiency. The only risk with that is that this reserve will be minimalized, and they might compromise on quality. Why would they compromise on quality? Because cost efficiency in the nursing home sector, if you want to minimize costs, the only way to reduce costs, one of the main ways is to reduce staff, and therefore you want to compromise on quality. The other thing is with reserves are minimalized, that can actually be of risk for the COVID-19 response, because if you don't have enough financial resilience to economic external shocks or epidemic crisis, you might be much more vulnerable. For instance, now we see that the number of residents coming to nursing homes are dropping, revenues are dropping, and therefore these entities who have minimalized their reserves are more vulnerable. The evidence actually says that the financial performance, so a systematic review shows that financial performance of for-profit entities are generally better in terms of efficiency and profit margins, but it also means, or that also was found, that they skimp on client and employee well-being, so lower staffing levels. And we already kind of referred to the quality of care, but there's another aspect to it, and there's the aspect of information asymmetry. It's information asymmetry between the provider and the client. And in a market like a nursing home market, where the client doesn't have full information about the quality of care in an end provider, it means that actually the for-profit providers are incentivized to provide measurable and marketable quality outputs. They still want to keep their revenue going, they still want to maintain income, but they will do so based on what defines their reputation. While what Kenneth Arrow, famous economist, wrote is that the non-distribution constraint actually signals institutions' objective, and therefore actually gives an impression of trustworthiness among patients, and therefore will be more willing or more able to act in the best interest of patients. So in a sector where information asymmetry is present, the non-profit sector in theory would perform better. What the evidence shows is in line with this theory, and shows that favor non-profit and for-public nursing homes over for-profit entities. And yeah, some systematic reviews argue that it's due because of the focus on efficiency. And lastly, the theory on responsiveness. The theory of responsiveness refers to the changing environment and demand. And different ownership types may respond differently to different environments because they have different capital structures. So for-profit entities can tap into private equity capital, while non-profit entities cannot. They mainly rely for big investments on bank loans or bonds. Back in the old days, it was also philanthropy funds, but that has dried up mostly. And that means that for-profit entities, because they can tap in private equity, they are generally more expensive, but also more risk-taking, and can tap into larger investment funds. While non-profit, as Hansman wrote, has trapped capital. In a nutshell, that means more that they will increase their capacity even when their surplus or then cash flow is zero, maintain the capacity even if it becomes zero or negative, while for-profit entity would exit a market where the surplus is negative. Most of the evidence comes actually from the hospital sector, and they see that for-profit hospitals are more responsive to increasing and decreasing demand than a non-profit and public counterparts. So what does this say for the case of COVID? So our hypothesis for a COVID case is that what we learned from the theory of efficiency is that due to smaller reserves and lower staffing levels, for-profit nursing homes may perform worse in their response to COVID-19. And the quality of care hypothesis would predict that because they already predict that the nursing home would skimp on staffing levels and underperform on quality of care, the impact of COVID-19 will be bigger in for-profit nursing homes. And responsiveness, the for-profit entities might be quicker to respond to COVID-19, But it also, this theory predicts that the for-profit entities will exit the long-term care sector more rapidly when it's financially unfavorable. And we kind of always saw that in the stock markets, where the long-term care, for-profit long-term care chains who are publicly quoted, those stocks plummeted during the COVID-19 crisis. So of course, there's a lot of mitigating factors. If you talk about ownership structures, everybody always asks a question about case mix differences. There is always a suspicion with for-profit entities that they cherry pick or they cream scheme, so they tend to try to get the more less severe clients from the market. The other aspect is of course size. So the number of residents per home, or being chain affiliated, or being a standalone entity. For instance, chain affiliation can have an impact on COVID-19, because if you are changing your personnel from different sites, that could increase the probability of spreading the COVID-19. Staffing levels, we already touched upon this, but of course reliance on agency staff is also an important aspect on this, because the private sector or is known to be much more relied more on outsourcing their staff. A degree of commercialization, we already touched upon it as well. The private equity owned providers, who tend to be, evidence seems to suggest, more debt inflated, and also how they try to roll up different sites into one big nursing home chain, which is one of the risks. The two risks: one is financial resilience, and two is also having multiple sites and increasing the size, which could make them more vulnerable to the COVID-19 crisis. Environment is also one of the things to think about, which area they position themselves in, but also the age of the nursing home, or what kind of nursing home. For-profit entities tend to have versus non-profit. For instance, in the Netherlands, you see they're much more very small entities, and also much more in old buildings, much more difficult to isolate certain people. While maybe in bigger non-profit entities, it's much easier to design or get one part of the nursing home, only assign those to COVID-19 clients. I made a brief overview of the empirical studies. It's not Cochrane standard, because I did not yet make a systematic review, but to get a certain gist of what's happening already, I'm quite impressed how quickly this goes already. I had to put it on two slides, and not all the studies actually included ownership status as main variable, but they did include it as a co-variable. And it's interesting that most of the studies come from the US. But the other part is that most of the studies so far have shown a worse performance of for-profit entities in their effective response to COVID-19. I have not included Amy's study in this yet. Amy can reveal her findings later. But another interesting part of these studies is that they usually assign the worst performance of the for-profit sector to that they, first of all, have limited number of staff, and also that they are bigger in size. So most of the nursing home chains are for-profit entities, and therefore also more likely to have COVID-19 or spread, where COVID-19 will be able to enter and will be easier to spread. So very briefly, a Dutch case. So I've been reporting, as Alina already explained, I've been reporting about the Dutch case from early on. And interesting enough is that, the figure says that approximately 30% of the deaths has happened in nursing homes, but it's very difficult to tell in Dutch case, because reporting of mortality is very difficult and especially very fragmented, and that means it's also very difficult to measure what's happening in the Netherlands at the moment. And at the moment, they are trying to improve the information in the Netherlands and trying to retrospectively trying to get a better grasp on it. And what we're trying to do is also trying to see how the for-profit sector has done so far in responding to the COVID-19 crisis. I have spoken to one big for-profit nursing home chain, and they, this is anecdotal of course, they said that they think they responded better to the COVID-19 crisis than the non-profit sector, because they have been much more quicker to respond to acquiring and buying up PPEs. Of course, we want to test this and we want to gather evidence on this, which we will be doing in the upcoming months. So a brief outlook from my side. I think there's two scenarios that could happen at the moment. I think we're in a very important moment where things will change, also in the nursing home sector. One of the things that could happen is that there will be greater public control, maybe a policy window where market composition might change, and where maybe tighter control mechanisms, but also where for-profit entities might get in financial distress, where the public sector might step in and buy up private sector. This is one of these scenarios. The other scenario is that actually the private sector will gain a greater role because of the spiraling public deficits. Public entities will try to seek private capital to actually make the large investments that we need also for the future, because of the demographic change that are happening. So there are actually two scenarios that could be happening in different healthcare systems. So this is the moment really for us to also inform policymakers to get a better grip on the situation and what ownership can contribute to financially sustainable healthcare systems. Therefore, the aim of this project is really to collect information from different countries and to provide an overview of what is happening globally. We also want to conduct a systematic review. As I said already, I made a rough overview of what's happening or rolled out of the publication press already, but we want to later on get a better systematic overview of the studies, their quality, what kind of measures they use, which data, etc. And the last real step is that we want to construct a multi-country data set and assess the relationship between ownership type and their response to COVID-19. Yeah, so at the moment, we really want to focus on nursing homes for older people who require permanent supervision, but this is not set in stone, and we want to kind of see how it goes. But at the moment, this is our focus. So one of the ideas that we want to collect information from different countries. Amy was already so kind to fill out her country and want to see, okay, what kind of ownership types are present in healthcare systems, and then we want to kind of see how has this affected the healthcare system. The COVID-19 has infected and impacted the healthcare system. So first of all, please feel free to contact us, especially if you want to collaborate on this project. What I felt to say is, if you have any questions, please, you can always post them in the chat box first. But we have in the end time to raise questions, and I might also refer back to those questions that you put in the chat box. And I want to give it over to Amy now.
Hello, everyone. Can you hear me? Is the audio working? Perfect. So good morning, good afternoon, good evening, depending on where you are. I love these global international webinars. It's always interesting to see where everyone's coming from and learn from each other. Let me share my screen. I'm hoping you're able to see the screen now. Oh, yes. I will just, perfect. All right, Adelina, you're floating at the top corner of my screen here. So I also do want to take this opportunity to thank you for organizing this webinar, but also this series. I think I personally have learned a lot through international collaboration through the pandemic. And, you know, we're still continuing to learn. And I think the opportunities to share what each country has gone through, each region has gone through, has really enabled us to reflect on how we can continue to improve care for older adults receiving care in different settings. And so, continuing from what Florien had just described, which is, first of all, that was excellent context. I think, Florien, that was really helpful, I think, for setting up my presentation, discussing specifically what has happened in Canada. And I'm actually located in Ontario, the province of Ontario, which is the most populous province in Canada. And the study that I will be presenting is actually data that we have collected provincially in Ontario. So in many countries, and definitely Canada is one of those instances where there wasn't a lot of awareness about what is happening in care homes. So when we're talking about care homes, nursing homes, long-term care homes, in the case of Ontario, we're really speaking about individuals who are residing in a residential care environment. This is congregate care living. And these are individuals who are highly dependent functionally and on nurses and personal support workers to help them perform activities of daily living. And so we know this is a highly complex, medically complex and frail population. But unfortunately, initially, a lot of governments were not paying attention to what was happening in long-term care homes or care homes until they started to see the increase in not only the number of cases, but also the mortality count. And so I want to sort of take you back to the end of March, which is when one of the largest cases in the province of Ontario, when the government first started to notice that there was actually very little preparation that was done to help equip the long-term care sector in preparing for this pandemic. And so unfortunately, where we are, based on our latest international report looking at mortality count, is that in Canada, deaths in care homes, of care home residents, represent 85% of COVID-19 related deaths in the country. This is not something that Canadians boast about or are proud of. And actually it has raised the discussion about what is happening, what are the systemic issues that existed prior to the pandemic, and what is happening in the care homes since the start of the pandemic in Canada. And so there has been a lot of focus on why is Canada so high in terms of the morbidity and mortality from COVID-19, even though we're not one of the countries with the largest number of deaths linked to the virus. And actually, the pandemic, the outbreaks in Canada started at the beginning of March in the long-term care home in the province of British Columbia in BC. So on March 5th, we had our first outbreak or first case identified in the Canadian long-term care home or care home. And I apologize for using these terms interchangeably. I'll try to stick to the use of long-term care homes. That's just the term that we're most familiar with in Canada. But for context, long-term care homes is equivalent to the use of care homes in the UK, for example, also nursing homes elsewhere. And so a couple of days later, after the first identified case in the long-term care home, we also had the first Canadian death, as well as the first long-term care resident to have died from COVID-19 in BC, which is on the west coast of Canada. And at the time, we started to think about what are some of the contributing factors to the outbreak, as well as the death of residents in care homes. And unfortunately, even then, there wasn't a simple answer. And so one of the earlier sort of dissection of the case in BC, this is the Lynn Valley Care Center, was that they recognized, and this is not something that was new at the time, there was a wide recognition that individuals with medical complexity, with multiple comorbidities, are at the highest risk of suffering severe outcomes from COVID-19. So at the time, we know that the residents who had not only contracted COVID-19, but had died from COVID-19, had a number of underlying health conditions. And this is not surprising. This is a study that my team had done a couple of years ago that was actually published earlier this year, where we looked at the characteristics of newly admitted long-term care home residents over 15 years. And as you can see, so this is the proportion of newly admitted nursing home residents or long-term care home residents who have a number of chronic conditions. And we see that over time, the proportion of residents with 7 or more chronic conditions has increased. And in fact, you know, the study ended in 2015. We have continued to see the extension of this trend. So this population is becoming more and more frail and dealing with a higher number of comorbidities upon entry. And many of them become more frail. Their health actually continues to decline as they age and approach the end of life while they're receiving care in the care home, long-term care homes. And so we know it's a highly frail population. The other aspect, which is actually related to the issue of staffing that I want to get to a little bit later on, is that we know that this is a sector with a high proportion of shared healthcare workforce. And many, especially healthcare aides or nursing assistants, they're known as personal support workers in Canada, they take multiple part-time jobs at a very low wage in order to garner sufficient income in order to make the sort of a living wage. And so even my recent conversations with some of the personal support workers in long-term care homes, now we're moving towards, there's single-site work restriction. We're moving towards a model where you're trying to compensate and provide full-time work for workers in this setting, but many of them are actually making less because not only were they working at multiple jobs, many of them actually had greater number of hours than full-time hours. So typically the full-time hours in Canada, it would be 37.5 hours per week, but many of these workers are actually working 40, 45 hours a week in order to make a living wage. And so this is problematic. One of the first studies that have come out looking at the epidemiology of COVID-19 in skilled nursing facilities in the US has identified that having shared healthcare workers, especially healthcare workers who were asymptomatic at the time, who were pre-symptomatic and who did not declare that they had symptoms and continued to work, was one of the main reasons or one of the main causes for the rapid transmission of COVID-19 from facility to facility. And recently, there's another study coming out of US looking at the prevalence of essential long-term care workers who work at more than one jobs. And as you can see that nearly 1 in 5 healthcare worker in the long-term care setting actually has a second job. And we're not talking about a second job where, you know, they would make occasional visits. They actually do spend a significant portion of their work week at a second site. And so this really speaks to the challenge of trying to stabilize and maintain the workforce, you know, when not only of the issue of shortage of staffing in general, but as the pandemic progressed, we continue to see an attrition of healthcare workers from the sector. So healthcare workers who have gotten sick over time, over the pandemic period, those who were required to quarantine, either because they were a positive case or because they were exposed to positive cases in the home. And so some of these long-term care homes actually were down to 50% of their capacity. And it doesn't only affect a single home. Because many of these workers were initially working in multiple homes, you can imagine that multiple homes were affected by the shortage at the same time. And so there's some challenges in terms of the workforce. And coming back to another point that Florien had mentioned earlier, there are also these environmental structural issues that more and more people have been speaking about. So challenges related to cohorting. So whether or not the facility not only had the space to cohort positive cases apart from or separating them from the negative cases, but also whether or not there was a quick enough response from not only from the individual homes, but from those who were part of the chain facility. So in terms of the level of command and administration, whether or not at the corporate level, there was a recognition that there is a need to cohort individuals and how quickly they were able to mobilize resources to enable that to happen. Those are some of the other challenges. And structurally, another issue that has come up in Canada is the issue of crowdedness or the challenges to having shared accommodation in these facilities. And in this case of the facility in BC, we see that there were 139 government-funded beds, and roughly half of them were in private rooms. And basically, private rooms are private or individual bedrooms where the resident also have access to their private bathroom. Many of the homes actually had semi-private rooms where you have two residents, so they have their private residential room, their private bedrooms, but they share a bathroom. So there was a bathroom that's shared in between. And there are still some facilities where you have multiple residents, not only in a room, so a ward room or shared accommodation, and you also have multiple residents sharing a bathroom in this case. And so these are problematic in terms of containing the spread of the virus, but also in terms of cohorting. So you not only have to move the individual who has been tested positive, you have to move everyone who's been exposed, so within close contact. So as you can imagine, in a congregate care setting, you not only have to try to separate individuals who have that shared living space in their bedrooms, in their bathrooms, but also the shared dining area. So there's a lot of challenges in terms of reorganizing and shifting individuals within these facilities, and the expediency to which you can make that happen will actually reveal how quickly the home and the facility is able to respond to the virus coming into the facility and preventing its spread. And so a little bit of information about the structure of the long-term care market in Ontario. As you can see here, we have four major types of ownership. So there's a municipal government-owned facility. So these are all long-term care homes are publicly funded, but there is a split of costs. So majority of the healthcare costs are covered by the provincial government, are funded by the provincial government. But the portion that is not fully funded is the accommodation cost. And this is the case in many other countries when you have a publicly financed system, but the accommodation portion, the residential portion, is considered non-healthcare. And so there tends to be an out-of-pocket cost for the accommodation. But the bulk of the nursing care, the personal support, the food and other costs associated with care provided in the long-term care facilities, long-term care homes, are actually funded through the provincial governments. And so in terms of operation, you have municipal government owned. So in Ontario specifically, each region, each jurisdiction is actually required to have a long-term care home. And so in many regions where there aren't private providers stepping in to provide long-term care, municipal government will actually step in to provide that service in order to fulfill the demand for long-term care. And so there's the municipal government-owned home. In terms of private homes, you have charitable homes. So homes that are run by registered charities. There are private homes that are run by not-for-profit entities. And there are, of course, private homes run by for-profit entities. And so as you can see, the private for-profit homes make up the bulk of the sector. They represent nearly 60% of the beds in Ontario. And one of the issues, as I mentioned, is that we continue to think about, why does ownership matter? And one of the really obvious challenges here is that when we look at the bed structure or the classification, which really speaks to what proportion of the homes are actually the private accommodation versus semi-private versus the shared accommodation, we see that the for-profit entity had the highest proportion of homes that are non-compliant with the redesigned, the new long-term care, the design manual for the long-term care homes. And the new beds, or the A-type beds, are the beds that are actually designed where you have at most two residents. So the semi-private structure, we have two residents sharing a bathroom. And those don't meet the new classification structure, or the A beds are essentially facilities where you have residents where you have multiple residents in the same room, or multiple residents, more than two residents sharing the same bathroom. So you see that in the private sector, we have a much higher proportion of residents who are in this situation with that shared accommodation and shared bathrooms. The other issue is location. So when you think about location, charitable homes tend to be more urbanly located. And part of that comes from the history, that a lot of these charitable homes originated from institutions that were shelters for the homeless, that were shelters for individuals who were unable to receive care. So prior to the institutionalization of nursing home care or nursing care, in many regions, it's actually a lot of the nuns and the religious organization providing care to those who were seeking shelter, who were seeking medical care, nursing care that weren't provided through a healthcare system. And so you see actually a lot of charitable homes that tend to service these underserved populations. 100, 150 years ago, they eventually were converted into long-term care homes or nursing homes. So they tend to be more urbanly located. But there's also the factor of what's driving the demand, right? So, with the concentration of the population in urban center, you also see that there is a demand potentially for a long-term care home in the urban center. So over time, you start to see an increase in the proportion of private for-profit homes coming into centers, leaving sort of the rural remote region to the services of municipal homes, where they're expected to fill the gap, and some private not-for-profit facilities. And when we're looking at, in terms of hours of direct care per resident day, we also know that, in the public and the not-for-profit sector, the hours of care tend to be a little higher. Speaking to Florien's point earlier about the compromise that are sometimes made in terms of level of staffing by private for-profit providers. So you can see that private for-profit long-term care homes in Ontario tend to provide slightly fewer hours of care in a typical day. And I'll speak to the implications of that a little bit later on. And so when we're thinking about the odds of what's contributing to odds of experiencing outbreak, I think more and more evidence is coming out that the geography matters more than ownership status. And in the case of Ontario, we actually see that nearly 90% of the outbreaks were in urban center. And so when we conducted our analysis, we actually had to separate the urban facility from the rural facilities, because we're actually starting to see differences in patterns of the role of ownership as well. So we see that in sort of the rural communities, one, partly because they have a smaller sample size. You can see the wide variation here, but the profit status actually did not matter in terms of the odds of experiencing outbreak. Whereas in urban centers, as I shown earlier, when you're looking at the charitable homes and the for-profit homes, they tend to be not only located in urban centers, but really in the highly dense areas within urban centers. So these homes, compared to the municipal homes, who tend to be more rurally located, have a greater probability of experiencing a COVID-19 outbreak. And this is just a sort of an illustration showing the distribution of where the homes are located in the province of Ontario. So this is the province of Ontario. We're born in Quebec, which is also another province that have experienced quite significant outbreaks from COVID-19 in their care home populations as well. And so as you can see, a lot of the rural communities, so Northern Ontario, they're serviced by not-for-profit municipal governments, whereas in the urban centers, one of the largest metropolitan areas in Canada actually is the city of Toronto. And you can see that in the urban centers, that's where the for-profit homes tend to be located in the more population dense regions. In the city of Ottawa, where I'm located, this is essentially the city center. This is where our parliament is located, actually. And you can see that in the city of Ottawa, actually quite a few of the not-for-profit sector homes are originate in areas where there was low income. And so these tend to be the underserviced area initially. So many of these not-for-profit homes are actually charitable homes in the Ottawa region, with a long history of affiliation with a religious organization or ethnic group. And then you see that there are some gaps that are filled by municipal government. And for-profit homes, while they are urbanly located, so this is considered a city center, they're urbanly located, many of them, you start to see that for-profit homes, they're starting to buy out plot of land that may be a little bit cheaper, but still proximal to the city center. So when we're thinking about ownership status and why it matters, it also speaks to where the homes choose to locate in response to not only the the demand for care, but also where they could actually maximize profits, right? So thinking about where a home might choose to build its facility, you can see that for-profit homes tend to be a little bit outside of the city center, where they still have access to the population that needs care, but potentially the land is cheaper. And another interesting observation is that, you know, many of these homes, as Florien had pointed out, are actually chain facilities. And so if you have a healthcare worker who's working across multiple homes within a chain, they're traveling often on public transit, right, from home to home. And so the exposure to community transmission of COVID-19 is also greater in the city center, and especially in corporate-owned facilities where you have multiple employees working across sites. And so in terms of the size of the outbreaks or number of confirmed cases, we do see that compared to municipally owned long-term care homes, all the private homes have a greater number of cases, partly geography. So you can see urban location doesn't make a difference. So partly it's geography, but partly it speaks to how the containment measures were introduced in these facilities. And one of the aspects that I wanted to point out is that in facility with the new beds or the A beds, where we see, you know, these are facilities with only semi-private or private accommodations, they have half the number of cases compared to those with at least one A bed or, you know, a mix of new beds and shared accommodation. In terms of resident deaths, you know, of course, as Florien mentioned earlier, one of the leading factor is the case mix index, or the case mix of the residents. When we had actually control for a case mix, we see that it actually does partially explain some of the variation in why residents have died, or the number of residents who have died. But in Ontario, it's actually a very interesting case in that there's not a lot of opportunity for cream skimming. So in Ontario, how residents are placed into long-term care homes are actually through a community home care coordinator who's distinct from the long-term care system, who's separated from the long-term care system. So they place individuals based on acuity, based on level of need. And so while the homes have some opportunity to reject residents, so they could say, oh, they might be too complex, we don't want to take this person on. But if the long-term care home does not have 100% or actually 90% occupancy, they actually have to return some of the funds back to the provincial government. So they're required through the funding policy, the funding mechanism, to maintain high level of occupancy. And so there isn't a whole lot of room for selection of the residents. There is some, but we do see that across the board that most of the long-term care residents, whether it's for-profit, not-for-profit, municipal, residents just have very high acuity. And so case mix, while it explains some of the variation that we see in terms of the outcomes across the long-term care homes in Ontario, they're not one of the main contributing factors in terms of the differences in homes that are operating under different ownerships. And so coming back to the case of Ontario, back to the end of March, you know, how do we get from just a handful of deaths, or 12 deaths in long-term care, to now, you know, in the country, you know, we have over 7,000 deaths, and 85% of them are coming from care homes. One of the things that I want to come back to is the policy measures that were implemented early on. And so as a result of the staffing shortage and attrition, early on in the pandemic, the Ontario government had actually issued an emergency order supporting the work deployment, the rapid deployment of workers within long-term care. So what that means is that homes now have the flexibility to rapidly redeploy staff within their facility or within their organization to other sites or other units within their homes. They can change the assignment of work, so allowing individuals to perform tasks that are not typical within their scope of work, and also allowing flexibility in terms of changing of the scheduling or the shift assignment. But as you can imagine, with the evidence that was coming out of the US at the time, we knew that having share workers or having workers that are widely dispersed and moving within the sector is one of the reasons for the rapid transmission of COVID-19 across the care homes. And so unfortunately, because of the initial measure to quickly redeploy staff to fulfill the staffing shortage, unfortunately, that may have actually contributed to the widespread of COVID-19 across long-term care homes in Ontario. And we can see that when we look at the breakdown of the types of home that actually had a self-declared critical staffing shortage, it was homes that, charitable homes located in urban centers, also the private for-profit homes, much more likely to experience a critical staffing shortage. And now kind of looking back into the odds of experiencing outbreak, we also saw that these were the homes that have the highest odds of experiencing a COVID-19 outbreak. And part of it might be their reliance on agency staffing as well, because they didn't have sufficient staff within the sector. So the reliance on agency staffing, we've also seen this case in the UK as well. Reliance on agency staffing have also contributed to the spread of COVID-19. So unfortunately, with the early attempt to stabilize the workforce, the unintended consequence of that may have been the introduction of, or have contributed to an increase of outbreaks in the sector early on. And so later on, the government did actually implement single site work restriction in April. So about a month later, when we realized, oh, there was a rapidly increased number of cases and mortality from long-term care, unfortunately, by the time that these remedial measures were implemented, you know, the virus has actually spread to almost a third of the long-term care homes in Ontario. And so by that time, the containment measure had to be much more severe, including the introduction of military, the Canadian Armed Forces coming into the long-term care homes to help with provide logistical support. And so we're now at the crossroads of trying to figure out, where do we go from here? And as I mentioned, there's no simple answer, right? So we're looking at all these factors related to ownership. So within the ownership, there's also these layers of containment measures, how quickly they're able to mobilize resources, not only staffing and workforce, but their capacity to acquire PPE, their capacity to you know, work with local public health units to get testing. You know, and so early on, we know that there wasn't sufficient testing of workers and residents in long-term care homes, and actually some long-term care facilities were able to leverage the connections that they have, and they were able to get testing earlier than some other homes. So, you know, there are many factors at play here. And of course, we also think about we also need to think about the impact this has had on the residents, right? So the residents in these care homes are at the center of this discussion. And we know that there's challenges in terms of social isolation, in terms of providing care to individual residents with dementia, and in terms of how the homes manage residents and manage the care during this time is also an important part of the equation. And of course, the impact on the staff as well, right? So not only, we're not thinking about not only staffing shortages, but what impact in terms of economic impact to limiting staff to working at a single workplace. Like I mentioned, you know, many of them rely on multiple places of in order to garner a living wage. So what impact this has had, these measures have had on the workers and their social and psychological well-being is also an important part of this equation. So I think ownership is just the tip of the iceberg. And now we actually have to start to dig deeper in terms of how does ownership influence not only the resident outcomes, but also the staff outcomes within the long-term care homes. And so there's tons of research. And so I think this is an opportunity for us to open up for discussion and hear about the experience in the different countries, the research that's going on, their opportunities, whether there are opportunities to collaborate, so then we can continue to learn from each other and continue to explore these issues further. And so my email's there, and also on Twitter. So please reach out if you see that, if you have questions, first of all, and comments about the presentation, but if there are opportunities to collaborate, I'd be happy to. So I will now stop sharing my screen and turn the floor back to Florien.
Thank you, Amy. That was very interesting. I will share my screen again. Yes. So this is the interactive moment of this session. What I would like you to do is you can get your phone, or you can also, I think you can do it with your computer, and you can go to menti.com and use that code, and I will join, and you can, your answers will appear on the screen. So the first question is, which country do you work on? So if you go to menti.com, I will invite everyone to join, and of course all the information is anonymous. I won't know who filled out the forms, but it makes it a bit of an interesting debate, or compile the interest. So I see already some questions coming in. I see Canada, Scotland, England, UK and Germany. I'll put mine, the Netherlands, in it. I'll give people some time to fill out. So quite some from England. So yeah, which country do you work on? I thought about which country do you come from, but I thought it might be much more of a contested one. So I thought, which countries are you working on? So it's interesting to see there's about quite some variety. So if everybody logged in, we'll go to the next question. If you think go to the next slide. The question is, nursing home services in your country are provided by mainly the for-profit sector. Does it have a large role? Does the non-profit sector has a big role? Or is the public sector big? I see some non-profit sector is relatively big in most countries, in the public sector as well. You can see there's quite some outliers. This is quite nice about this visualization as well, is that you see some humps going, especially in the public sector. Some of them are mainly public provided, I guess. So it's interesting to see already, kind of, which aligns to the graph that I showed earlier. It's quite different compositions of the market, where both the for-profit sector or the non-profit sector and the public sector that quite differs. So I will go to the next slide. So most of the evidence from your country suggests that the for-profit nursing homes underperform in terms of quality of care, accessibility and efficiency. Of course, only if you can answer it. Maybe for Norway, it might be more difficult to answer this question. But for other countries, it's maybe a bit more straightforward. And of course, this is what you've read and what you know. So it seems a bit more 50-50 in a way. How you can see that some of them actually, some people mentioned that the for-profit sector seemed to underperform regarding quality of care, but it seems to also lean towards more to disagreeing that they actually perform similarly or better. But accessibility seems to also lean more towards underperformance. But efficiency, it seems more that the for-profit sector is more efficient in a way, or that the expectation or the what people suggest that they do. So to get a bit of an idea, do you think that the nursing home sector has become more commercially oriented over the past 40 years? And I picked the 40 years because around 1980, the new public management movement started, which I skipped in my slides. Hence, I had a bit odd number of 40 years. Yeah, so most people agree with this question, that they've seen a shift in their nursing home sector, which doesn't surprise me, which aligns with most studies, that there is more of a commercial, leaning towards a commercial long-term care sector. So now back actually to the COVID case. It seems that in my country, so your country, especially the for-profit sector, has been unable to respond effectively to the COVID crisis. Do you disagree or agree? And then more specifically, the second question is about private equity-owned nursing homes. So this is more about your impression. Of course, it's not very scientific what we're doing, but we're trying to get a bit of a grasp of what the experience is and the views of what's happening. So I will also contribute. I'm sorry for the negative framing of the questions. I just realized they're quite negatively framed, which isn't, I just realized now by looking at the questions that it is a burden. I had to make a statement. I should have maybe positively framed it. Yeah, so most of the impression of that most people get is that the for-profit sector has been unable to respond effectively to the COVID-19 crisis, and more specifically, private equity owned. The impression is that the private equity owned have been more unable to respond. So now it's more of an open question. I've helped you out a bit, but maybe you can give you a bit of your opinion in short text of what the risks and opportunities are. Because there might also be, opportunities associated with for-profit nursing homes in your country. So there are some answers rolling in. So someone is saying more accountability towards the service provider, considering the for-profit is forking his or her own money, operational size, a low occupancy. So yeah, we talked about that. Reputation damage and falling occupancy, yes. Risking one more project. Is there anyone who wants to share one of his or her thoughts on this? Let's go to the chat. Sorry, I'm multitasking here. I can't see the chat window. Adelina, can you help out?
Yes, we have, in fact, we have more questions and comments on these specific questions, but if anybody would like to comment, maybe Patricia, are you?
Can I come in?
Okay.
This is Hassan from UK. The main reason why the nursing home were affected more was because there was no government support. Initially, all the PPE was directed to NHS, and we were just exposed. So the main reason why there were more deaths in nursing home in UK was the lack of support of the government.
And I think it's Patricia here from Canada. That Amy's done a great job sort of summarizing a number of factors across the different nursing homes. But I would say a big factor is that we found that long-term care facilities weren't nearly prepared from an IPC perspective, both in terms of training and readiness, because we didn't have nearly the same problems in hospital or acute care that we had in long-term care. And then also you mentioned the access. Not only did they not know how to use the equipment, but when they didn't have access to the equipment. So it was really only the fact that they were given access through ministry and other sectors that, and they were given training, that things improved.
I do want to add to Patricia's point. I think a lot of the challenges within long-term care is that lack of training with IPAC. And from what I've heard from a couple of homes is actually, you know, the chain of communication is actually quite broken in some of these homes, in that when you have shift work, you can have a worker coming on shift in the morning And they receive instruction from one charge nurse where they're saying, yes, you have to wear a mask with all the patients or all the residents. And then they can come on another shift in the evening where the charge nurse might tell them otherwise. And so there was actually quite a bit of challenge in terms of consistency of direction coming from management. I think part of it was just that they didn't know how to prepare for the COVID-19, and that IPAC training would have been really helpful for the sector. And I think that's actually one of the logistical supports that long-term care really benefited in terms of what they got from the local hospitals who have provided support. So the IPAC training, the not just the supply, but IPAC training and providing support around that, and also from the Canadian Armed Forces, the logistical interventions.
Thank you. There's another comment from Malta, from Maria Aurora Fenet. Do you want to unmute yourself, Maria Aurora?
Hi. No, basically, we did not have any COVID-19 related deaths in care homes. So basically, I'm just querying whether it was because of the sizes of the homes, whether it was that we had more time to prepare, or because of the instant lockdowns. And it would be interesting to look into this further. Just putting this comment, just that.
Can I come in? The other reason in the UK was the change of guidance by the Public England. You see, they kept on changing the guidance. At one point, they say use PPE. At one point, don't use PPE. Only use mask, only use gloves, which created a hell of a problem getting all different guidances. And the other reason was the discharge of COVID patient to nursing home without proper specifications.
I'm keeping with the chat box. Is that okay, Florian? Yeah. So
Yeah.
there's another question from Jasmine Ma. Jasmine, would you like to unmute and pose it?
I'm just echoing some of the experiences I think everyone said already, but where I am in Canada, I'm in Halifax. We did have a kind of a soft, like, no acceptance policy from a long-term care home. And as well, we did push a lot of acute patients just in preparation for a COVID wave back to the periphery.
And adding to Jasmine's point, I think it's really interesting that initially, I think this is maybe what Hassan was getting at. Initially in terms of regional planning of bed flow. So a lot of places in Ontario, long-term care was part of the bed flow from acute care. And so the intention was to actually transfer some of the stable patients into long-term care homes that had beds available, so convalescent beds. And at least from what I've heard from the sector was that the initial intention was to transfer them without waiting for full testing results to return, because there was an urgency of trying to clear the hospital beds. And I think that brings up another challenge with health human resource planning, in that now, you have hospitals who are willing to provide support to long-term care homes because they're operating at 30% to 50% of their typical volume. But once the hospitals are back to normal operations, there's even a greater shortage of healthcare workers, right, supporting the long-term care sector. And now with the single site work restriction, you have workers who typically serve 1 to 3 other homes. And now, they're only allowed to work at one side. There's obviously financial implications and repercussions for the worker, but just overall as a sector, there's going to be huge oncoming challenges for us in terms of how do we respond to future waves when 1 in 3 homes will be missing a worker because of the single site work restriction. And on top of that, you have COVID-19 and other illnesses that are occurring concomitantly, right?
And may I check, Steve Allen, is that okay if I invite you to comment a bit on some of the work you've done with data from care homes, the UK at PSSIU?
Yeah, sure. Thanks, Adelina. In terms of work we've done at PSSIU, we've been looking at a couple of areas around the impact of COVID-19 on care homes. So firstly, we've been looking at, we were looking very initially at the start of the outbreak in terms of how location of care homes might impact on the requirement for resources for healthcare. But then that obviously was usurped with the spread of COVID within care homes, and so we've now looking at a number of different avenues, including looking at workforce and looking at how they have dealt with it. And so we have a project funded by the Health Foundation, which we've got some extra funding to look into how care home staff and social care staff in general, not just care home staff, but all social care staff have felt about what's happened during COVID, during this COVID-19 outbreak. And then secondly, I've done a little bit of work looking at the underlying factors and how factors such as profits, the sector of a care home, how that impacts on the quality of a care home, because we're doing some research at the moment in terms of looking at workforce and how that impacts on quality of care homes in England. And we've been including sector and type of care home, whether it's a nursing home or a residential home, as covariates in this analysis. So we've been able to look at that and find that underlying it, we do find that for-profit care homes will have lower quality ratings and in general. And so then the argument becomes, how would that impact on COVID itself as well? And so that's kind of a brief overview of the work that we're doing at the moment at PSIU.
Thank you, Steve. I was also wondering, there's one person who commented also on the accountability of for-profit providers in the Mentimeters. Someone wants to respond to that?
I think the private sector are governed by CQC. So there is an accountability. You get a rating on what it is. There is also a very strong regiment of safeguarding. So the private sector are monitored accountability both through the government and obviously if you are a profit making through your shareholder and directors, you make sure that you provide a good quality of care to achieve what you want. But the CQC, which is a public sector body, has also the responsibility to check on what is done in a care home.
Thank you. Are there any other comments related also to the opinions that are coming up? Are there other people who want to comment on this specifically?
Yes, my name is Andrew Teasdale. I'm actually an economist and a CFA charter holder. And I do, the last few years, I spent a lot of time doing investor advocacy. I'm on the Ombudsman Consumer and Investor Advisory Council, and I've been doing some research into this particular area. I find it interesting. I think really long-term care, it needs to be dealt with by a social enterprise model. I don't really think you can price care for providing ADL tasks. I think you really have to look at the wider social and emotional needs of the human and the community interactions, and also addressing intrinsic capacities with respect to delivering ADL. So I think it's very difficult to deliver on a pure for-profit basis. So I think that's the major problem. The other thing is that we really don't know what the actual model is. We have hourly rates of direct care of 3 hours and, you know, standard deviation in that. We have suggested hours of like 4 hours of direct care that's being provided by the RNAO, but we really don't know what the optimal model of care is to, you know, fully give meaning and capacity and personal growth to individuals in long-term care homes. So I think that's the biggest problem, is actually finding out what that big model is and trying to get information and data and look at what part of that model can be met by the public domain and what part of that model is going to have to be delivered by wider community collaboration and integration. So I think we have to look social enterprise. I think it's way beyond the for-profit and the not-for-profit divide. I think there is a bigger picture here. And I don't really think that what we're dealing with at the moment, we haven't moved beyond it. And that's part of the problem with the independent reviews that are going to be looking at the sector. They're really just going to be focusing on COVID, what caused COVID. I think we need to look further. Anyway, just some input from myself.
Can I say something? I mean, fundamentally in the UK, the issue is that 25% of all care beds are owned by large corporate providers who are opaquely owned, i.e. they're owned by private equity companies. And we have the whole situation where the only way they can make a decent return on their investment is by maximising their economies of scale. And therefore you have the whole factorization, industrialization of personal care in a home setting, and therefore what you have is large homes with multi units on them. That is a significant risk in COVID. Now the evidence is pointing to the fact that, you know, the larger the home is, the more potential there is for a cross infection of COVID at this moment in time. Added to that, of course, the CQC, which is the English regulator, has in their state of care reports regularly mentioned the fact is that they have concern regarding the quality in large care homes, and those are care homes with more than 50 beds. Most of the actual prevalent model for a large corporate care home is to be large. I mean, the standard model for a Bupa care home is to be 120 beds. And it's interesting because when I looked at your Canadian data, how that model is also replicated in Canada with the private sector providers being an average of 110 bed units. Now, the interesting, we keep on having evidence presented now that the bigger the home is, the more chance of you having COVID, and so that, and also that what's happening is if a home gets COVID in the first place, then there's more. Once it's in, it's more liable to go through that home than if you don't get COVID, and so therefore the majority of deaths are in a smaller number of homes. So all that, we're at this moment in time, we're in a perfect storm of large number of industrialized care homes who are also wide open. If they get an infection, are then wide open. So it's, we're talking about you was talking there regarding the agency staff situation, and it's more prevalent. And it's not just about agency staff. It's not just about their own staff. It's about their prevalent model. So it's more fundamental than that. I went to a presentation whereby all the large corporate providers in the UK in England are basically for sale, and there they said they are viewed as property companies. They aren't viewed as care companies, and so therefore you have a system that's involved where companies are seen as investments in property, not in delivery and care, because of the corporate model that's in that place. So it's a very complex situation, and also we're also in a very weak and non-transparent situation, because our large corporates are owned by opaque financial structures, private equity and stuff like that. So really you can't bottom out the actual financial operational costs and efficiencies of these organizations as well. So it is a very, very challenging environment we have at the moment.
Thank you very much for sharing your interest or your insights. And I also things that also triggered me is that we also see in the Netherlands, but we also see in other countries that for-profit entities seem to also split the home component with the care component, where the house is being part of being better able for private investors to invest in, while the care component is still publicly funded the home component is more of the commercial business to it, which
that's one of the reasons a number of years ago, one of our large corporate providers went bust because of that disconnect between who owns the buildings and who delivers the care, Southern Crofts. And so therefore, that model still exists in the UK, and it's a dangerous model despite what people say. And it's where you overvalue the rental income you get from your provision. So it is it is a dangerous position we're in at the moment. Also, the situation, we have a large number of deaths in particular homes, and so therefore you have a large number of a large vacancy level. Therefore, the financial viability in the short to medium term of these homes is compromised as well. And
yeah.
all, you know, sorry.
No, it's a very, very good comment, and I just want to add to that is that most of the for-profit providers also, especially private equity owned, really depend on a constant cash flow. And at the moment that is being disrupted because of the black swan in a way, or the disruption. There's just no cushioning to be able to absorb this external shock, and which I found very, very concerning in a way, because now or the public sector has to step in, fund them, or yeah.
And also they depend on a high occupancy level as well. So therefore, the lower the occupancy level, the less financially viable they become.
Yeah. Yeah, so yeah, it's super interesting. Mick, you're from the US, I suppose, or?
No, I'm from England.
England, sorry. Sorry, I didn't catch your accent well. Any other comments or any questions?
I just wanted to add on. I am from UK. I am in the business since 1986. And initially, where the registration was done by the local authority, you were not allowed to provide more than 40 beds. And I think that was the concept where, you know, you have a unit of 10 each where the care was given. Once the this corporate started coming on, the first corporate company was Tech Care, who was building 120 beds at a go with 30 beds unit, with a skeleton staff, and that's where it all started. I think it is the question of how you deliver care to small unit of people, and how you can look after your staff if you have a one-to-one. In corporate companies, what I find that the manager has no say. It's all done by the manager above. So they find it very difficult to manage their homes.
Thank you. If there are not any other questions or comments, I might give the floor back to Alina. If there's anything, any people who want to collaborate on this project again, or have any thoughts or questions, I'm more than happy to receive emails and to respond to those. As I said, we are really seeking out collaboration from different countries. We might also send some emails to different country correspondents to ask for some information to really get a good overview of what's happening in different countries. So I'm really excited and glad to do this project, and I'm very looking forward to collaborate with you all.
Thank you very much. I saw a couple more comments. I don't only need about 1 or 2 minutes. So if anybody else would like to quickly jump in, especially if you're not from the UK or Canada or the Netherlands, because we've mostly heard about, or Malta. They are the countries we've heard about. Any last minute comments? I also see quite a few comments now of appreciation, and I'd like to add my personal one. This has been a fantastic session. I think also you've really moved us on as well in terms of using COVID and helping make these, it's not COVID, sorry, it's in my brain, I meant Menti. I just, that word just keeps coming up. Sorry. So that was a great use of Menti, and it worked really well. And I think it sets the bar high for the next webinars we've got coming. As I said, next week we've got, not the next webinar in 2 weeks is the 3rd of August. It's going to be about unpaid care. We'll take again an international perspective. We will start with a more international overview of what are the issues. I think that will be presented by Clara Lorenz, who I think is currently at the call. And we will then have some initial empirical evidence. We've got at least one study that already has some initial findings on the impact of the pandemic on unpaid carers. And we are looking for more. So if you've got a study, if you've got some initial findings or some thoughts that you'd like to share, or even if you've got a study you're designing and you'd like to share your thoughts on how you're going about this, we can make some space. We will have short and long presentations depending how far the studies are. And we're very happy also to have other suggestions for sessions like this one today, where one of you may have already started on a topic and would like to have some international feedback and contrasting of ideas. So please let me know if you've got any suggestions for other topics or if you'd like to carry this. I hope Florian, Amy, you'll be coming back to share your findings later on when you've had a bit more data and more collaboration as well. The webinar is being recorded. It will go on the website. Usually it takes about 1 or 2 days. And I think that is all from me. We've got 5 more minutes. If I don't know, Amy, Florian, would you like to have a last word?
Yeah, because I didn't see the chat box when I was sharing my screen, so I just see one of the comments of Leonor. I'm not sure I'm saying her name right, or him. I'm not sure. But what I quickly want to respond to about the question is, I was wondering where you think, in case in the Netherlands, for example, the opening up of nursing homes and loosening the measures will show a great difference between for-profit and not-for-profit nursing homes. Which is it's a very good question. Is one of the things I skipped in my slides, that the role of the for-profit sector is very important in every healthcare system. So you have kind of a rival provider, you have a dominant provider, but you have also a parallel sector. In the Netherlands, the for-profit sector, for-profit nursing homes are much more of a parallel sector, more kind of contrasting themselves towards the traditional one, which means also that they tend to profile themselves to comply less to very strict, rigid rules and be more open, and therefore they also claim, but it's all anecdotal, have been better able to respond to the COVID crisis because they have been less bureaucratic, put it that way. And if the measures will be loosened, I guess there will be more of an aim to get more transparency in the for-profit sector, because there's more interest now in to get more of an insight in the for-profit sector, because they have operated under the radar for quite a long time. So I was trying to type I've responded now this way. Thank you all for all your input. I really appreciate all the insights and thoughts, and I'm very happy to see so many people joined in and collaborate. Looking forward to see you collaborate with you in the future.
Amy, do you like to have some last word?
No, thank you so much. Thank you everybody for attending and for such a well-organized webinar. I certainly learned a lot, so looking forward to hearing from everyone.
Thank you very much, and we'll see you all in 2 weeks. I've shared my email, and you can also use the contact form in the website if you'd like to contribute to future webinars. As I said, it will all be shared on LTC COVID. You can always subscribe to the website, and then you get a notification in the morning, in the UK morning, when the new posts and the recordings are available. So have a great day or evening, everyone, and thanks again. Bye, and thank you, Amy and Florian. Bye.